Ladies and gentlemen, thank you very much for the kind invitation, dear Theo. Thank you for your friendship over the years. I was asked to talk about the endoscopic aortic valve replacement, which we perform at our hospital in Zurich since 10 years, or more or less. This is our hospital. It's the Hirslanden Clinic in Zurich, in the middle of Zurich. It's a 350 bed facility. We are the third largest cardiac surgery unit in the country at the moment. And as I said, we perform the surgery on aortic valve endoscopically or minimally invasively since more than 10 years. But let's go back. Cardiac surgery. This is a picture taken in the 60s at the Texas Heart Institute. This is Denton Cooley operating on a coronary artery bypass graft surgery, and the visitors from all over the world were visiting there, and we have to say, but at that time, cardiac surgery was very cool, obviously. And today, different story. Cardiac surgery, considered not innovative. We operate more or less alone with an assistant. They say cardiac surgery is too traditional. Stiff competition is present with the interventional cardiologist and has a low career opportunity for the surgeons. But why is that? I think it has to do with how we do the surgery. This is isolated aortic valve replacement surgery in the hands of a surgeon, which we have been doing for many, many years, like this, median sternotomy. Patient is in the ICU for 2-3 days, in the hospital for 7 to 10 days, rehab for 3-4 weeks, and then maybe if he goes back to work after 3 months. So this is what we have been doing for many years. And this is what the interventional cardiologists are doing with the same pathology. So this is Mick Jagger. You probably have heard. He had aortic valve stenosis, severe symptomatic aortic valve stenosis during his world tour 4 years ago, I think. And then he got a TAVI in New York, I think, somewhere. And he had to stop the world tour, got the TAVI, and then more or less 6 weeks later, he resumed the world tour, and he was full on stage performing as before. So this is the difference. Cardiac surgery, interventional cardiologist. And the numbers are like this. This is the latest, or let's say from 2022, the trend of TAVI versus SAVR in the United States. And if we split them up between the age groups, so below 65, it's an even 50-50 relation, TAVI versus SAVR, but in the age population over 65 to 80, it's almost 85 or 89% for TAVI and 12% for SAVR. And if you go higher in the age group, so above 80 years, more or less, there is no SAVR anymore. So the trend is clear. TAVI is on the rise, and SAVR is almost close to extinction. And extinction, maybe you know that. It's not new, but just briefly, everybody knows the story about Nokia. I had a phone, the Nokia 3310 in 2000, and everybody had a Nokia. So the Nokia 1100 was the bestseller cell phone at that time in 2003. But what happened then? This is a concise timeline about Nokia's important moments. So Nokia operating profit went from 1 billion in 1995 to 4 billion in 1999. They sold the most cell phones in the world. They had, like in 2007, half of the market share belonged to Nokia. In 2007, Apple came around, started the iPhone, and Nokia didn't change their strategy. So they continued with their product. The high-end phones continued to decline. And in just 6 years, the market value of Nokia declined by about 90%. This is the stock price history of Nokia in 2000, more or less. There was the climax of the stock price above 50 euros a share, and the decline was at 12 years later, more or less, or 10 years later, a share costed only €1.90 at that time. And then they got sold off. This is a famous quote by Stephen Elop, the CEO at that time. We didn't do anything wrong, but somehow we lost. They couldn't figure out what they did wrong, but they realized that something was going wrong. Nokia was a good case study for many business schools around the world. So they made studies about why Nokia fall, and they came up, all of those studies came up with 3 reasons why Nokia falls. So first, Nokia's technology was inferior to Apple's technology. The arrogance among top-level managers, they didn't want to change, they didn't want to listen to the mid-level managers, and also they had no vision. So the lack of vision was very important. So if we want to transfer that to the surgical community, to surgery, to, let's say, aortic valve surgery, how is the technology for the surgeons? I think surgery's technology is not inferior to the TAVI procedures. The results are good, technology is actually good, and outcome is good. But what about the arrogance compared to the surgeons compared to cardiologists? Maybe the surgeons always thought, well, we don't need to change. We're too busy. My practice is full. I don't have to change my technique. So maybe a little arrogant. What about the lack of vision? Would a surgeon have a vision or lack of vision? I'm not sure, because the surgeons always were in the forefront of innovation. But as I said, they were too busy operating, so they couldn't actually realize the vision, what they wanted. So I think we have to go back and see what really does the patient want. Of course, the patient wants a small anesthesia, whatever that means. They want a small incision. They certainly don't want pain. Pain is bad. And they want to be discharged very early. So this is important to know and to apply to the technique of the surgery. So we came up with a minimal invasive endoscopic valve surgery. But this is just a technique. And I think what Theo also mentioned, the ERAS concept or the ERAS protocol is very important. ERAS has nothing to do with Taylor Swift, so don't get me wrong, it's a scientific term. It says enhanced recovery after surgery, and is very important in our mind. But always the same question, what is minimally invasive? The surgeon's dilemma. Surgeons always say, my way is the best way. I don't care what the others are doing. There is no standard protocol how we should operate minimally invasively. But as you know, there are advantages, and the advantages of minimal invasive surgery are proven in many, many studies. This is one by Santana and Lamelas from Florida many years ago. They compared the surgery of patients, obese patients with sternotomy and versus mini thoracotomy, and they showed that the mini thoracotomy patients fared much better compared to the sternotomy patients. So the 30-day mortality was much lower, post-op complication much lower, deep wound infection, you name it. So it's proven in many other studies that minimally invasive surgery has an advantage. This is our approach. We have a right mini thoracotomy as a standard approach, so it's a 3-4 centimeter incision in the second intercostal space. You can also switch to the axillary incision if you want, but the technique is more or less the same. We have a peripheral femoral cannulation for the heart-lung machine. We started with a cut down, but now we move to a percutaneous a cannulation with a pre-closing device, the ProGlide, which we learned also from the cardiologist how to use it, and that avoids any lymphocele and seromas in the groin. But the mini thoracotomy, as I said, is a second intercostal space. Camera port is in the first and second intercostal space here in blue. We do not spread the ribs, it's just a soft tissue spreader. Chitwood clamp is in the second intercostal or third, here in red, and the pleural drainage in the fifth intercostal space where we also insufflate the CO2 for the surgery. We also use facilitating tools like the core knot, very important in our institution, so you don't have to tie the knots by hand. So we do it with a core knot, very fast and reliable. We used in the past also sutureless valves. We don't use them anymore. We just use regular bioprosthetic valves nowadays. This is a view of the aortic valve. We put some commissural retraction sutures so we have a better view and can fill around the bits with a view to the valve with the sutures. Then we resect the valve. We put mattress sutures, felted sutures, as we would do in an open stenotomy case. We seal the valve with the sutures, and then we close the aortotomy in regular fashion. So no changes in technique if we would do it via median stenotomy. This is the result of the patients when they go home at day 5 or 6, so they're mobile. They have more or less no pain, and they're feeling much fitter than if they would have a median stenotomy. But for a short time now, we're also embracing the ERAS concept, the ERAS protocol, and I think the ERAS protocol really is a team approach. It involves the general practitioner, involves the anesthesiologist, the intensivist, and also the nurses on the floor who are really crucial to this protocol. So it starts preoperatively, as Theo already mentioned. We treat anemia in all the patients, so we infuse them, we give them IV iron before the surgery. We tell the patients to load their carbs before the surgery, so they should eat some spaghetti 2 days before they go to the hospital. We give no sedation, and the night before the surgery, intraoperatively, the anesthesiologist only use short-acting anesthesia, a PUNF protocol, so the PUNF prophylaxis, meaning post-operative nausea and vomiting prophylaxis is very important, so then you can extubate the patient early so they have no nausea. Adjusted fluid management, very important, so they don't get too much fluid during the surgery. Tight body temperature control, very important, so the body temperature doesn't drop below 36 degrees. And a multimodal pain control is very important during the surgery, also post-operatively. But post-operatively, we early extubate, so we don't extubate the patient in the operating theater, we extubate the patient in the intensive care unit. They get an early mobilization by the physiotherapist, early removal of the drain and catheter, and also the multimodal pain control is being applied. This is just an example how we do the surgery. When we start at 8 o'clock, operation ends at 11:09, arrival at the ICU, 11:30. The patient gets extubated 1 hour later in the ICU, so 12:30. Physiotherapy comes 2:30, early family contact, also important, 4:30, let's say. Drain removal, if nothing comes out of the drain, at 5, and then we do a chest x-ray. If everything's fine, the patient gets transferred to the normal ward at 6 p.m. And then the nurses on the ward need to be ready for that. They need to know how to do if anything happens. But this is, as I said, it's a team approach. So team approach, this is Eliud Kipchoge. Maybe you know the guy. He is a marathon runner. He's the world record holder in marathon. He was the first man to actually finish a marathon below 2 hours, so under 2 hours. Why do I mention this? Because it's also a team approach. Everybody thought this would be impossible to do for a man to run a marathon under 2 hours, but he did it. But how did he do it? It was a team approach, as I said. So he had 35 pacemakers, and each of the one of the pacemaker ran with him only 1 kilometer. And then after 1 kilometer, the second pacemaker came and ran with him the second kilometer. So the 35 pacemakers kept Kipchoge under 2 minutes and 50 seconds per kilometer for 42 times in a row. So this is a real team approach, and not only Kipchoge, but it is the team who made it possible. So in conclusion, catheter-based aortic valve replacement has surpassed surgery by far. This is no news. The trend is very clear, and I hope it's not going to extinct the aortic valve surgery, but the vision and the concept is important to regain market share in a valve treatment. So I think minimally invasive has a place to stay, but it's a team approach, as I said. And with the ERAS program and the ERAS concept for early recovery, it's even more possible that we can regain momentum and get back on sustainable surgery. Just briefly, if anybody says the surgeons have no vision, this is the vision of a surgeon. Operation at home. The vision is one thing, but realization is the other thing, and we leave it at there. I don't know if that's going to be possible at some point. Thank you very much for your attention.
Great talk. Thank you so much for coming and giving this beautiful speech to our conference. And thank you for the contribution to the world literature. It is very important that we apply all this technique combined with the ERAS concept to everything we do a cardiac surgeon in all programs. And that's obviously very important. And it's, I think it's very important to also emphasize, and maybe part of a study in the future, that such an endoscopic approach compared to TAVI, because we know that at least we do have, even that the TAVI valves are getting better and better, we do have two significant key points as of now. The chance of paravalvular leak and the possibility of pacemaker is still extremely low. So if we combine those things with the approach as you described, maybe there is a possibility that the endoscopic saver, at least for a specific patient population, is going to be still a valid option.
Yes, that's our opinion as well. So we have to stress what we're good at. So we have to stress that we can do very good surgery for the patients with low complications, no pacemakers or more or less low pacemakers, no paravalvular leaks. But this is, we have to, we have to let people know that this is what we can do.
Greg? Fantastic talk. Thank you very much, Professor. Is it on now? I think it's on now. Thank you very much for an outstanding talk. I think you raised a lot of key points. What I would like to also note is that it was exceptional that you showed that you've gone to a percutaneous approach for your cannulation. And so this shows something that I think not everybody realizes, not even every surgeon realizes, is that surgeons have been using wires to do procedures from day one. Whether you're inserting a central line, or whether you're putting an intra-aortic balloon pump in, or whether you're using ProGlides, as you did, in order to do your cannulation, surgeons have been using wires since day one. So, it comes without surprise that there are a number of surgeons who are actively involved in TAVR today, TAVI, whatever you'd prefer to call it. So I think really that's what the future will bring. So I think if you want to, as a surgeon in the future, have a big aortic valve practice, you need to have a transcatheter practice, and then you need to have a traditional surgery practice, which will no longer be traditional, but it will be what you showed, with the minimally invasive surgical options. However, patients, whenever faced with any kind of incision, are you going to stop my heart, doctor? Are you going to put me on the heart-lung machine, doctor? I've read about various things, doctor. I'm not sure if I want that. If you have the transcatheter option to give them as well, and then you can weigh the pros and the cons. There will always be patients getting mechanical AVR, but I don't think we should limit our practice to only those patients. So if we want a pool of the biological AVR patients, I think we owe it to ourselves as a specialty. And now in the United States, in order to graduate as a cardiac surgeon, you must have a certain number of TAVRs that you've performed independently. This is where the specialty is going. So I think you showed us the one arm, and the other arm is the transcatheter approach, but I think more of us, you're right, need to move to this approach that you're showing for our aortic valve replacements. Thank you so much. It was an inspirational talk.
Thank you, Greg, for the concluding remarks. Any other questions from the audience? Foti? The gentleman in the far back.
Yeah, thank you. Congratulations for your presentation. It was very interesting indeed. I have a question for you. You said that you don't extubate on table the patients, but I think that the newest approach is to extubate them on table. What is your information towards this approach? Thank you.
Yes, thank you for the question. It's more like a logistic reason why we don't extubate the patient on the table, because we are in a private setting, and time is money in the OR. So if we want to have a faster transfer of the second patient, so we have to get the patient out of the OR, so they don't extubate because it takes longer. So it's the reason. It's only that.
Jörg, we shall thank you. Thank you very much for coming over. Thank you.